Assalamu alaikum. This lecture about hypertensive emergency in pregnancy. We'll talk about eclampsia. Objectives: to define gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with pregnancy, and differentiate between these terms. Understand pathophysiology of hypertensive disorders in pregnancy. Identify risk factors. Recognize potential complication, maternal and fetal, and develop management plan for eclampsia. Hypertension is the commonest medical problem during pregnancy. It's complicates about 15% of pregnancies. Also, it's the leading cause of maternal morbidity and mortality. Hypertension accounts for 1/4 up to 25% of antenatal admissions and is the commonest cause of iatrogenic prematurity. Regarding physiological change, as we know, blood pressure is directly proportional to systemic vascular resistance and cardiac output. In spite of increase in cardiac output during pregnancy, there is decrease in blood pressure, mainly due to vasodilation effect. Vasodilation in pregnancy is mediated by hormonal change, mainly progesterone, which is promote synthesis of nitric oxide by endothelial cells. So, blood pressure is decreased in early pregnancy up to 22 to 24th week of gestation, followed by steady rise to pre-pregnancy level up to term. Following delivery, there is immediate fall of blood pressure, followed by subsequent rise, reaching its peak between 3rd and 6th day of postpartum period. This is regarding physiological change. Pathogenesis of hypertensive disorders. There is a failure of trophoblast invasion into myometrium, and maternal and spiral arteries don't undergo their physiological vasodilation. Type: normal in pregnancy, there is invasion by trophoblast into spiral arteries wall. This invasion occurs in two stages or two waves. تمام. First, between 10 to 12 weeks. In this first wave, there is invasion of the decidual part of spiral arteries. تمام. The second wave of invasion occurs between 16 to 18th week of gestation. At this step, there is invasion of myometrium. تمام. Myometrial part of spiral arteries. As an end result of this invasion, there is remodeling of spiral arteries to become low resistance, low pressure, high flow arteries. But in preeclampsia, there is a failure of second wave invasion of spiral arteries, result in hypoperfusion of fetoplacental unit. This pathogenesis involved in two stages. First, abnormal placentation and other development of maternal syndrome, which is a subsequent to abnormal placentation and placental ischemia or placental hyperfusion. In first stage abnormal placentation, the spiral arteries fails to adapt and become high capacitance, low resistance vessels. The invading placenta is unable to optimize its blood supply from maternal uterine vessels, which result in uteroplacental ischemia. This ischemia either to abnormal implantation, as we mentioned, or in relatively large placenta, which occur in multiple pregnancy, diabetic mothers, and hydrophobic fetus. These other causes of uteroplacental ischemia are part of abnormal implantation. Stage 2, which is a maternal response as a consequence to placental hyperfusion. Normal pregnancy associated with systemic inflammatory response, but in preeclampsia it is an exaggerated inflammatory response, which results in higher level of pro-inflammatory cytokines produced associated with endothelial dysfunction. This endothelial dysfunction leads to increased capillary permeability. Prothrombotic factors produced result in platelet activation and increased vascular tone. Classification of hypertension in pregnancy divided into either its pre-existing hypertension, chronic hypertension, or pregnancy-induced hypertension. Pregnancy-induced hypertension or gestational hypertension, either non-proteinuric PIH or preeclampsia, which is associated with proteinuria. PIH, by definition, is an elevation of blood pressure more than 140/90 in two readings 4 hours apart after 20 weeks of gestation, not associated with proteinuria in a previously normotensive patient. So, to differentiate chronic hypertension from PIH or gestational hypertension, the gestation age is an important differentiating point. Any rise in blood pressure prior to 20 weeks of gestation is most probably associated with chronic or pre-existing hypertension. And PIH differentiated from preeclampsia by proteinuria, in which PIH is raised blood pressure not associated with proteinuria. Pre-existing or chronic hypertension, either diagnosed prior to pregnancy or blood pressure raised for 20 weeks of gestation. Women with pre-existing hypertension at an increased risk of superimposed preeclampsia, which is diagnosed by new onset proteinuria in previously hypertensive patient. Preeclampsia defined as new onset hypertension after 20 weeks with one or more of the following criteria: either new onset proteinuria, new onset maternal organ dysfunction, or uteroplacental dysfunction. Uteroplacental dysfunction or placental insufficiency result in oligohydramnios, fetal growth restriction, preterm labor, and even placental abruption. This is a manifestation of placental insufficiency. Maternal organ dysfunction, either renal, hepatic, hematological, or neurological manifestation. So, preeclampsia hypertension after 20 weeks with either proteinuria, maternal organ dysfunction, or placental insufficiency. This is a crisis in preeclampsia, which can occur either eclampsia, which is the topic of this lecture, HELLP syndrome, pulmonary edema, placental abruption, cerebral hemorrhage, cortical blindness, DIC, disseminated intravascular coagulation, AKI, acute kidney injury, hepatic rupture, or transient left ventricular systolic or diastolic dysfunction. This is a possible crisis or maternal complication of preeclampsia. HELLP syndrome, H stands for hemolysis, elevated liver enzymes, and low platelet. The commonest cause of death in preeclampsia is cerebral hemorrhage, followed by multi-organ failure and liver or hepatic rupture. Fetal complications of hypertensive disorders in pregnancy, either IUGR, intrauterine growth restriction, preterm birth, which is the commonest cause of iatrogenic preterm delivery, low birth weight, increased risk of stillbirth, and neonatal complications result in NICU admission, and RDS, lower respiratory distress syndrome, due to prematurity. This is an introduction for hypertension in pregnancy. We'll talk about eclampsia, the topic of this lecture. Eclampsia is an obstetric emergency, refers to one or more generalized tonic-clonic convulsion and or coma in the setting of preeclampsia in the absence of other neurological conditions. It's rare to occur prior to 20 weeks of gestation in the absence of gestational trophoblastic disease. As we mentioned, in GTD, there is early onset preeclampsia prior to 20 weeks. Eclampsia can occur either antenatal, intrapartum, or postpartum. Risk factors, either obstetric risk factors, general, or medical factors. Obstetric risk factors, either previous history of preeclampsia, primary, long birth interval, IVF, in vitro fertilization, high drops, and multiple pregnancies associated with large placenta, and hydatiform mole, which is gestation trophoblastic disorders. General factors, age, mainly associated with teenagers and advanced maternal age more than 40 years, obesity, and family history. Medical factors, chronic hypertension, chronic kidney disease, diabetes, either pre-existing or gestation diabetes, antiphospholipid syndrome, and connective tissue disorders. Differential diagnosis of eclampsia rule out neurological, metabolic, infectious, and drug toxicity. Neurological causes, example, epilepsy, infectious, meningitis, encephalitis, and malaria, cerebral malaria. Metabolic causes, example, hypoglycemia and poisoning or drug toxicity. This is the differential diagnosis of seizures. Management of eclampsia. It's an obstetric emergency. Be calm and don't panic. Don't panic to avoid unnecessary intervention and tragic complications. Don't leave the patient alone. Call for help. Arrange for eclampsia box to be brought. Is it safe to approach the patient? First, your safety and safe environment to approach the patient. Prevent maternal injury during convulsion. Place the patient in semi-prone position, left lateral position or recovery position, which is allow unconscious or semi-conscious patient to breathe and prevent aspiration. Use ABCD approach. A stands for airway, B breath or breathing, C circulation, and D for drugs. Regarding airway, protect airway and maintain its patency, prevent aspiration, maintain oxygenation, binary breather face mask, 10 liters per minute to prevent respiratory acidosis. Circulation, first check for pulse. If absent, initiate CPR and call arrest team. If positive pulse, put the patient in recovery position and displace uterus to prevent aortocaval compression by gravity uterus. Secure IV access, draw sample for investigations, fluid by infusion pump, and insert Foley catheter to monitor urine output and fluid balance. Investigations, full blood count, including platelet, urea electrolytes, serum uric acid, liver function test, coagulation screen if platelet less than 100. Group and safe for cross-matching, and urine for proteinuria. This is the general management for convulsion. Specific management of eclampsia: anticonvulsant to prevent further seizures, antihypertensive, strict fluid balance, fetal surveillance if viable, steroid for fetal lung maturity, and timing of delivery once patient is stabilized. Follow-up postpartum and documentation. Regarding anticonvulsant treatment, magnesium sulfate is a drug of choice. Mechanism of action: it's a membrane stabilizer and neuroprotector. It's reduced sensitivity to acetylcholine at a motor end plate. It also blocks neuronal calcium influx. Don't use diazepam or phenytoin to abolish the initial seizure because it's a self-limiting seizure. These drugs cause respiratory depression and risk of aspiration, especially if administered in combination or followed by magnesium sulfate. Also, phenytoin is less effective than magnesium in controlling eclamptic seizures. So, magnesium is the first-line treatment and drug of choice for eclampsia. Prevention and treatment. Magnesium sulfate has a narrow therapeutic range. Its use necessitates close monitoring of respiratory rate, oxygen saturation, and tender reflexes. As magnesium is excreted in urine, so monitor urine output. Early sign of toxicity is loss of deep tender reflexes. Toxicity treated by stop infusion of magnesium sulfate and administer antidote, which is the calcium gluconate. Side effect of magnesium sulfate or symptoms of toxicity is neuromuscular blockage, loss of tender reflexes, double vision, slurred speech, respiratory depression, and finally cardiac arrest. Regarding controlling hypertension, a severe hypertension results in loss of cerebral autoregulation. This is a risk of cerebral hemorrhage, which is the commonest cause of death in eclampsia. First line treatment is labetalol, which is a combined alpha and beta adrenergic blocker, and second line is hydralazine, which is a peripheral vasodilation, result in relaxation of arterial smooth muscle. These drugs available in injection form and tabs. In an emergency situation, for example, eclampsia, administer an injection of labetalol as a first line or hydrazine as a second line treatment. Fetal surveillance by continuous electronic fetal monitoring and delivery once stabilized if antenatal. As the only cure is delivery. To determine mode of delivery, do vaginal examination according to Bishop score. If cervix is favorable, deliver vaginal. If not, deliver by urgent cesarean section. And make sure don't attempt delivery unless patient is stabilized. Administer steroids, corticosteroids for fetal lung maturity. In a summary, management of eclampsia divided into general and specific management. In a general management, it's an obstetric emergency. First, call for help. Don't leave patient unattended. Prevent patient injury. Protect airway and maintain patency. Prevent aspiration and ensure oxygenation. Circulation. Check for pulse and blood pressure. Secure IV line. Draw sample for investigation. Administer fluids and insert Foley catheter. D stands for drugs. First, anticonvulsant therapy, which is magnesium sulfate, is a drug of choice. Antihypertensive, first line labetalol, second line hydralazine. Fetal monitoring if antenatal. Administer steroids and termination when patient stabilized. This is the end of the lecture. Thank you.